Good afternoon. I'd like to welcome everyone joining us today to learn about treating uncontrolled or medicine-resistant epilepsy. My name is Julie Ninichka-Reed, the Director of Holy Cross Health's Comprehensive Neuroscience Program. We're going to dive right into answering some questions we've received, but first I'd like to call your attention to a few ground rules that you'll see in the comments section. We encourage you to participate, but please keep any questions and comments general. We won't be discussing anyone's specific health situations in this public forum. If we can't get to every question today, we'll provide additional feedback through Holy Cross Health's log, or we can connect with you one-on-one through our program channels, by phone, email, or website. Remember, any comments you make here are public and visible to others watching. So enjoy. Let's join me in welcoming our two physician experts in treating epilepsy. First, we have Dr. Gregory Matthews, an epileptologist and the medical director of Holy Cross Hospital's Level 3 accredited epilepsy monitoring unit. Also joining us is Dr. Zachary Levine, a neurosurgeon and the medical director of neuroscience and neurosurgery at Holy Cross. So let's start with a few questions we've already received. Could you tell us, what is the reason people suffer from seizures?
I can answer that. Most people have seizures for reasons that we don't really understand. A fraction of people who have seizures, they're caused by injuries to the head, strokes, tumors, congenital malformations, but most people, there really is no identifiable cause. So we call those folks idiopathic epilepsy.
Is there a cure for epilepsy?
We don't think of epilepsy treatment in terms of cures for the most part, because most people who have epilepsy, we can maintain control of their seizures with medications. And if you get the right diagnosis and the right treatment, you can live seizure-free with medications.
Great. Is there a specific way to diagnose epilepsy?
Well, epilepsy, the diagnosis is made through clinical history. So, of course, you have to have some sort of historical information about the patient's seizures, what they're like. Usually somebody has to have observed them and described them. And then in terms of the confirming the diagnosis, we use a technique called electroencephalogram, or EEG, which is a way to monitor the brain waves and to look for abnormalities that tell us that there is something abnormal within the brain circuitry.
Wonderful. So tell me, what are some of the latest treatment options for having epilepsy?
So as I mentioned earlier, most people who have epilepsy will do very well with medications. And there are many different medications, so we have many options to try. If for some reason one medicine doesn't work, we have another one to try, and so on. We try to find the right fit for that person in terms of maximizing the control of their seizures and minimizing their side effects. What we really want to talk about today, though, is the smaller percentage of patients whose seizures are not controlled with medications. And in these situations, some of them may be candidates for a surgical treatment, and that's what my colleague, Dr. Levine, does.
Yeah, so surgery also is a way in which we help define the seizures. So even though we have patients who are treatment resistant from medication, and we think we know where these seizures are, often we need to do some sort of surgery to further define those seizures, and then we can sort of figure out what would be the best course of action from a surgical perspective. So some of the surgery isn't just for resulting in diminishing the seizures or eliminating the seizures. It's actually to better define the location and type of seizure that's going on. So these two things work in conjunction to get us the best answers, and then we can move forward to sort of the curative mode of treatment from surgery, which would be a number of options that are available.
So one of our listeners wants to know, what are some of those curative treatment options?
So we divide surgery for epilepsy into a couple of components. So there are ways in which we can modify the output from the brain to decrease the electrical activity which is causing the seizure. And then there's the other avenue where we actually remove tissue in order to eliminate a seizure. So many of these seizures are caused by lesions in the brain. They can be tangles of blood vessels, they can be tumors, they can be congenital malformation, as Dr. Matthews mentioned earlier. And these we often eliminate. We remove them. And that's what we're going to call ablative surgery. And then the seizures diminish. Sometimes we find an abnormality in the brain that we have to remove in order to get results. Sometimes there are multiple abnormalities or multiple foci in the brain that medicine isn't treating, or it's in such a location that if we remove this part of the brain that's causing seizures, we're going to cause significant neurologic problems. Could be weakness, could be loss of speech, could be other neurologic symptoms such as loss of vision, that we can't sacrifice those areas. So in that situation, we do something called neuromodulation. And that's where we actually implant circuits into the nervous system to help modulate the electrical activity which is being produced by the seizure. And this helps diminish the symptoms and in some cases can eliminate all seizures. So those are the two avenues we look at for surgical treatment of epilepsy. Do you have anything else, Phil?
No, I think that's right. I think what the most important thing to get started with is understand what kind of seizures you have and whether there is a specific place in the brain where they come from. And we have, as I mentioned earlier, this technology called electroencephalogram, or EEG, which looks at the brain activity. And if we do monitoring of brain activity, which we do here in the hospital in a part of the hospital called the epilepsy monitoring unit, we can capture seizures as they're happening, and we can pinpoint where they're originating from in the brain. And that's the first point to then decide, is this something that we can cure with Dr. Levine's techniques, as he mentioned, or is this something we can try to suppress or diminish with other kinds of technologies?
So we're constantly working back and forth to figure out, first of all, can we get away without doing any surgery? And that's the first line of treatment. So that's where Dr. Matthews is really the expert. But there are those few people that we have to say, hey, look, there actually is a lesion in the brain, so do we need to do further investigation and find out, more about these seizures? Or that we don't see anything in the brain that we think is abnormal, but we can see one focus in the area based on that surface EEG, we may have to do some investigation. So Dr. Matthews and I meet on a regular basis, and we discuss which patients are the candidates for what kind of treatment. And then we decide, after we've gone through this exhaustive set of options, what's best for that patient, and then move forward from there.
Thanks. I want to remind everybody that if you have questions, remember to put them in the comments so that we can answer them. And then related to that, Sharon wanted to know if you're treated with surgery, such as you've been describing, does that mean that I don't have to be on medications any longer if I have epilepsy?
Well, I'll start off a little bit about that. So when I counsel the patients about surgery, I told them the goal is to decrease your seizures and to eliminate your seizures if possible, but not necessarily to eliminate the medication. Now, there are side effects with medication, but really that's kind of comes out of my hands. And that's where Dr. Matthews really takes control and sort of understands what's best for the patients.
So I think it's important to understand that many patients who come to us with uncontrolled seizures are on 2, 3, 4 medicines sometimes, and they're still having seizures. So they're not only having seizures, but they're experiencing the side effects of the medications. And so one of the goals of surgery is to, as Dr. Levine said, try to completely stop the seizures. But if we could stop the seizures, even though the patient stays on the medicine or is able to reduce the medicine so that they're living seizure-free on less medicine, we consider that a successful outcome. Yes, we don't expect all patients who undergo surgery to be able to come off their medications, but we do hope that they can at least reduce, maybe come down from being on 3 medicines to 2 or 1 medicine and still remain seizure-free.
Lana would like to know, what are the risks associated with this procedure?
So depending on what surgery we're going to do, and I'm going to break this down a little bit because they're 2 totally different operations: the neuromodulation or the implanting of circuits into the nervous system versus removal of brain tissue. So the neuromodulation, depending on what we're doing, the side effects can be almost none. A slight cough when the stimulator is turned on. This is what's called a vagus nerve stimulator, where you stimulate the vagus nerve, which sometimes diminishes seizures. You can get an occasional cough, and the hospital stay it's an outpatient procedure. We go into more complicated neuromodulation. We're putting electrodes into the brain. The complications can be quite troublesome. You know, the rate of having a complication from that is very small. It's about 1 to 2%, but it is brain surgery. When it comes to the ablative surgery, that's brain surgery, so there are issues with that. But the outcomes from both of these are quite good. So we expect from neuromodulation about 30% reduction in seizures if we're doing vagus nerve stimulation. For brain stimulation for seizures, you can eliminate most seizures. And then for the ablative procedures, where we're either removing parts of the brain or somehow removing something that is causing seizures in the brain, the outcomes are really quite good. The most innovative thing that we're doing right now is something called laser ablative therapy, where becomes almost an outpatient procedure where we're able to remove a portion of the brain which is causing seizures using a fiber optic sort of wire that's implanted very precisely into the brain, and then using the MRI as a guide to remove this portion of the brain that's causing seizures. And these people go home the next day, or could conceivably go home within 23 hours of the operation or sooner if everything goes well.
Linda wants to know, what makes someone a good candidate for surgery?
That's sort of more. We do this together, but I'll let Greg start with that. So.
Well, so a patient with seizures will often be seen by a neurologist, of course, and the neurologist is the one who is going to try to work with medications. And as I mentioned earlier, there are many medications to choose from, but what we've learned from experience, from clinical experience at clinical research, is that once you've tried a couple of medicines, let's say 2, 3 medicines, and you're not experiencing complete seizure control, the chances that you're going to live seizure-free with medicine starts to diminish quite rapidly. So in other words, if you're saying, look, I've tried, medicine A, didn't stop my seizures. Now next I tried medicine B, didn't control my seizures. Now I'm on medicine C, and I'm still having some seizures. At that point, we start to think about surgery, because we start to worry that this person is someone who won't respond to medicine. And we don't want to spend the next 10 years trying medicine after medicine after medicine if we know it's not going to work. So not that we push people to look at surgery. We don't push anything that isn't appropriate for the patient, but we like people to know early on that if you're not doing well, you received a diagnosis of epilepsy 2 years ago, and you're still having seizures, you should know all of your options, and you should know that some sort of surgical procedure might be what changes your life. And you should know that sooner rather than later, because, of course, epilepsy is very disruptive to your life. Epilepsy prevents you from driving. Epilepsy prevents you from being able to do a lot of things that you like to do. So we try to get people evaluated at least early on so that we know what our options are.
And sometimes having seizures, as you have more seizures, that begets more seizures, and it becomes sort of a vicious cycle. So once Greg's determined, hey, look, Dr. Matthews is determined, hey, this is somebody who may need surgery, we sort of get together, we look at imaging studies of the brain, we look at the history and what we call the semiology, or sort of the presentation of the seizures, what happens during these seizures to this patient, and that helps us break down, okay, are we looking at somebody who would be better off with neuromodulation or implantation of circuits into the nervous system? Is this somebody who would be better for a surgical resection? And sometimes it requires further investigation of actually implanting electrodes onto the surface of the brain or in the brain to monitor the seizures even more closely. And so that's the first entertainment of surgery. Do we, is this something that is surgically treatable? And if so, what are our steps to get to that surgical treatment? Do we require some more invasive monitoring to really be sure? Or can we just go ahead and start thinking about surgery and getting the patient involved in the decision making? Because it's not always cut and dry that one option is your only option, even in surgery. So we like to involve the patient and their family in what makes sense for them and what we believe makes sense in that circumstance.
So Kristen would like to know what the recovery looks like after surgery.
So I'll talk about the immediate postoperative period, and then Dr. Matthews can address the more longer-term stuff. So again, it depends on the surgery. If we're talking about laser ablative surgery, the incision's 2 millimeters or 3 millimeters in length. There's no hair that's shaved. You go home the next day. You come back to the office 2 weeks later, and you have a suture removed. And for the most part, people feel a little headachy for the first day. They maybe feel a little bit out of it, but they get back into their regular activity by about 2 to 3 weeks. For more extensive brain surgery, it can be up to a 3 or 4 day hospital stay. You're in the ICU for a little while, and then you go home and you come back to see the surgeon in the office in about 2 weeks, make sure the wound looks good, and then slowly get you back into your regular life. Now, while this is going on, Dr. Matthews is involved in looking at the medication. And I'll let him address that in a minute. And then for the neuromodulation stuff, like I said, there's one thing called vagus nerve stimulation, which is stimulation of the vagus nerve in the neck. That's an outpatient procedure, and most people get back to their regular activities in about 4 or 5 days. For brain stimulation, we usually let them go home the following day, but it usually takes a good 3 to 4 weeks to recover from a surgical perspective. But from the other perspective, Dr. Matthews is also monitoring these patients, and we're communicating, and I'll let him address about medication and other issues.
Well, so of course, the first thing when a person has gone through a surgical procedure is everybody wants to know what's the result, have the seizures stopped. And, depending on how frequent your seizures are, we may know that right away, or it may take a while, depending if you have one seizure a month, we may not know for a couple months if your seizures have completely stopped. So we usually keep people on their medicines that they started on, and just to monitor things closely. The concern that a lot of people have, and I think I hear this very frequently from my patients, is, are you taking out something from my brain, and what's that going to do to me? And I think probably everyone listening is thinking that. And what I find amazing about this procedure that we're talking about, the types of procedures we're talking about, is if you're talking about an area of the brain that is causing seizures, something's wrong with that part of the brain. It's not normal. It doesn't function normally. If you put electrodes in the brain area that's causing the seizures, you see lots of abnormal electrical activity. That area of the brain is not participating in the normal, everyday cognitive functioning of your brain. So we're not talking about going in and taking a piece of your brain that's essential for your thinking, speaking, understanding, feeling, remembering, all those things. We're talking about areas that are abnormal. Now, not all surgery is as precise as that, because sometimes the seizures come from a wider area, and we have to resect tissue that we're not quite sure how much of a role it plays in normal everyday function. We do our best to assess that. So we do lots of preoperative testing. We look at cognitive functioning. We look at ways to figure out where people's speech areas are, where people's memory function is. And we use all of the information available to us to put all of that together and decide who is a good surgical candidate, who will likely have little, if any, side effects from going through the surgery. And we would hopefully inform the person of all of the possible outcomes to help them make an educated decision with us. And, you know, I should just add that in some cases we can go in and Dr. Levine can go in and do a very specific ablation of an area that essentially has no side effects. The person has absolutely no residual effects from having had that surgery.
And the whole point of like all this preoperative testing that we do and all of the communication that we have back and forth is to really minimize what would be harmful to the patient and maximize what would be beneficial. And that's really our goal, and that's why we tailor things to every individual's needs.
So one of our listeners, Tabitha, wants to know, how do you choose medications and what are you seeing success with?
Well, that's, first of all, it's important to know what kind of seizures the person has. Not all seizures are the same. So there are people who have epilepsy because of a genetic predisposition towards that. It just runs in the genes. And there are certain types of seizures that come with certain types of epilepsy that respond better to one medicine than another. So if we know something about the person, their seizure types, and the background, we can better choose the right medicine. But in the end, there's a very individual response to medicines. And some people are going to do really well on one medicine and for whatever reason, not so well on another medicine. And there's some trial and error to that. I think that even though I do this every single day, I still sometimes experience this medicine was just not the right one for this person. And they came back and they had a side effect, or they came back and it didn't help their seizures as much as we would have thought. But what you do is you identify that and you move on and you learn and you keep working at it. So there is no one best medicine, and I don't think ever will be, because people's responses are so individualized.
So you mentioned that there's not one good medicine, but one of our Facebook watchers wants to know about the effects of long-term medications for seizures, particularly because they have a son who's going to want to start driving soon. He's 18. And how do you address medications and allowing them to drive?
Well, so one issue that's particular to childhood epilepsy is that, and I'm not sure if this is the reason for the question, but some children outgrow their epilepsy. So it's important as well to identify what type of epilepsy, what specific characteristics are there, and is this something that the child might outgrow and might not need medication. If that's the case, we like to know that before they start driving, because what you'd have to do would be to come off the medicine. And if we do that once they start driving, once they're out there, got their license, there's no good time to stop the medicine. So we try to do that before they get their driver's license and start driving. And there's other tools that we can use to help identify that. If they have the type that they're just not going to outgrow, then the key there is get them on the medicine that's keeping them seizure-free and let them go and live a normal life. If they're not seizure-free, we still have work to do, and that's where this comes in with the evaluations for different types of treatments. I should say, getting back to the previous question and this question, that being at least able to choose the medicines that have the best chance of working for that individual really requires some degree of specialty, of special training, of special background, special experience. So I urge people who have epilepsy or have a loved one with epilepsy to, and if there's ongoing seizures or issues with the medications, you should really be seeing somebody who has the background in this, that you're not fumbling around with things that aren't working and losing precious time.
So Genesis wants to know, do seizures affect other parts of the body?
Well, depending on the seizure type, yes. I mean, seizures, when you have minor seizures that are, kind of staring off and spacing out, probably not. If you have major seizures, convulsions, the biggest problem with that type of seizure is actually injuries. People fall, people get hurt, people have dislocated shoulders and joints from their seizures. And again, the critical thing is to get them under control as soon as possible.
And that's one of the main reasons we'll do surgery if somebody is having seizures such that they have drop attacks, but they really don't have a medicine that's helping. Even if we can eliminate some of these falls and drops, we may not be able to completely reverse all of the epilepsy, but if we can keep them from falling, we keep them safer. I mean, that's kind of where we are with treatment of seizures from a surgical perspective in that particular circumstance.
So we're just about out of time, and I want to thank everyone for tuning in today. If we didn't get to your question, we're planning to provide additional feedback through Holy Cross Health's blog, or we can connect with you on one-on-one through our neuroscience channels. You'll see the website up there and a phone number that you can reach out to us, and we'll get you to the right person to answer those questions. But I wanted to ask Dr. Levine and Dr. Matthews if you had any final thoughts on some of the questions that we've asked today.
I think they were all good questions. I think the important thing Dr. Matthews pointed out is that you have to be evaluated. If you're having seizures, you have to be evaluated by an expert, and where there's a team and where there's a program that's going to evaluate everybody individually and tailor the care. And that's kind of what we do at our epilepsy center. And we collect all of the neuroradiologists, the neurosurgery team, the neurology team, and the neuropsychology, all the testing that's done, and we evaluate in a sort of a holistic way. Greg?
Absolutely. And, it's unfortunate that a lot of these newer technologies and techniques we're talking about are not going to be well known out even among community physicians. So there are people who practice neurology who are wonderful, wonderful doctors, but they may not have experience with some of this technology that we have here and may not be able to recommend them. And so I think that my recommendation to patients and their families is you have to be proactive. If you're not happy with how you're doing, if you're still having seizures and you don't think you've been offered all the options that are available, you need to go out and find a specialist. You need to ask the question of what else is available. And this is where we can help.
So again, thank you everybody for tuning in today on Facebook Live to see our episode on epilepsy and some of the treatments. Your questions were great. Some of the questions we didn't get to today, we will definitely make sure that we answer those for you. I want to just mention that we do have an epilepsy support group here. You can find that information on holycrosshealth.org. We have sessions coming up for the remainder of the year. And again, thank you to Dr. Matthews and Dr. Levine for participating with us today. And remember, if you have any questions about our program or want to connect with either one of these physicians, please reach out to us and we will make sure that you get that information. Thank you and have a good rest of your afternoon.